Sandra has focused her professional career on health, wellness, and caring for those who have been impacted by illness. Sandra holds a master's degree in science and nursing from McMaster University and a master's degree in health science bioethics from the University of Toronto. Sandra has had an extensive career in healthcare, serving 16 years as pediatric nurse practitioner and over 10 years as a healthcare ethicist. Sandra's career has focused on supporting patients, families, and the community with end-of-life care planning, educating and supporting healthcare professionals on caring with compassion for the dying patient, assisting clients to navigate the moral, ethical, legal, and technical landscape within the Ontario public and private health system. Sandra offers community and professional education on advanced care planning, goals of care, and serious illness conversations, aging well, and death and dying. Sandra is a master trainer in the Serious Illness Care Program and is project lead for end-of-life care planning at Hamilton Health Sciences. Sandra is also a certified yoga instructor, providing senior yoga classes aimed at improving health and wellness as we age. And with that, turn it over to Sandra.
I'm so glad to hear that many of you were here last week. Now I can't see the poll this time. Last time I could because I think I was listed as a participant. So what we're going to do today is we're going to review the healthcare planning. So I'll just briefly go over that. We're also going to look at a framework for end-of-life conversations. We're going to talk about the benefits to clinicians, patients, and families. And then we're also going to do a demonstration. So the case that we had last week, the son is actually here today, and we're going to have a conversation that looks different than the goals of care conversation. And then we're also going to hear a little bit about the family's perspective on the end-of-life planning. So the poll question that we have next is, how comfortable are you talking with your patient or their family members or substitute decision maker? I often will interchange family and SDM about end of life planning. So moving from the goals of care into more planning for those last maybe days, weeks to a year of life. So extremely comfortable, somewhat comfortable. I could use a bit of coaching and help. I have no idea how to approach end of life planning. And Tina, since I can't see them, maybe you can share.
Yes, I will do that. There are still some responses happening. Okay, just give it another few seconds.
Yep.
Okay, so we've got, nobody has said extremely comfortable, 47% somewhat comfortable, 33% I could use a bit of coaching, and 20% help. I have no idea.
Okay, great. So not inconsistent at all with what we've been hearing from health professionals across the country, but also we did an environmental scan at HHS about 10 years ago, asking about end-of-life practices. And almost everyone who responded said that they really didn't feel they had the capacity to engage in these really challenging conversations around end-of-life planning. So, you know, that's why we have decided to bring this type of program to HHS to, and I know many of you are not from Hamilton Health Sciences. I know you're from across Ontario, but this is a program that's across Canada. So probably many of your sites have somebody that's doing some training around the serious illness care program. And so, you know, it is something that health professionals have definitely told us they feel they would like a little bit more capacity building. You know, you have skills in your toolbox already, but what else can we do to make this feel a little bit more comfortable for ourselves and to get it right for our patients and families as well? So the next thing I'm going to ask you is, how do you approach end-of-life planning? So when you do engage in discussions, do you wait until the patient and family bring it up and then you take their lead? Maybe you have a systematic approach that you use, or maybe you consult with a colleague who's better at these conversations, or maybe you choose to consult a team like the palliative care team or a pain and symptom management team.
Okay, I'll just wait for a few more responses.
Yeah, a little bit of this is reflective practice too, right? To see where the pulse is for ourselves on where, you know, where we think we might be.
Okay, I still see responses, so just another.
Okay. Yeah, no problem.
Okay, well, I'll start giving I won't close the poll yet, but I wait until the patient or family bring it up is 36%. I
Okay.
have a systematic approach is 7%. I consult with a colleague who is better at these conversations, 29%. And I consult with the palliative care team is also 29%.
Okay, so quite a split in sort of how you do it. And you may also be trying to figure out, okay, which one do I do most? And maybe you do a little bit of all of them, which makes sense too. So just back to what we review, just as a review of what we talked about last week. So we've got this idea of the different types of conversations that happen during our life planning. So right from the very beginning, when we don't face a serious illness, when we're just healthy living individuals, that's what we talk about advanced care planning. And most important thing here is identifying who's going to make a decision for you and sharing your wishes and values with them. Then we talked last week about goals of care. And this is really about when we have a diagnosis in front of us and we're trying to decide what are the best options for this patient. We're going to our expertise around evidence-based medicine, our experience that we have with that clinical situation. We're also asking the family and the patient what it is that they would want for themselves. We're offering treatments and we're giving risks, benefits, the advantages, the disadvantages, what would happen if somebody didn't accept the treatment, and then we create our care plan. So that's our goals of care. Everyone should have goals of care who enters into a health facility. Serious illness, I'm going to go into a lot more detail about what that is, but that's really when we are worried a person has a short lifespan left to live. And we want to give them the opportunity to start really thinking about what's most important to them. And we also want to add that to our care plans, like so for our limits of care, for our CPR discussion. And so a lot of those recommendations are based on the wishes, values, and beliefs of the person. And we need to figure out a way how to find out that information, but also prepare them for that end of life. And also a big part of this is breaking bad news, right? Like sharing that poor prognosis that there's limited time left. And then the last one, the code status. So this is at the very end of life when your heart stops, your lungs start to fail. What do you want us to do? So DNR does not mean do not care. It means do not resuscitate. So we have to focus that conversation on just the resuscitation and not all the other care management that we would do for that patient. And that's often a conversation that's meant to be on its own. So you can just see by this diagram, very few people that we'll be interacting with will actually move into needing a code status conversation. It doesn't mean that most people in hospital won't need this, because this is a depiction of the general population. So yeah. So serious illness, what exactly do we mean when we say serious illness? So it carries a high risk of death over the course of a year. So the disease that you have is there's a risk of death at least within the next year. So that often people will consider as our surprise question. So would you be surprised if this person died in the next year despite receiving care? And if your answer is no, I wouldn't be surprised, then that person would be considered somebody who would benefit from palliative services, including a serious illness conversation to help with all that planning. It also has a strong negative impact on quality of life and functioning of life roles. So this person is being impacted as their disease progresses, their function is starting to decline, the quality of their life is starting to be impacted by the disease. And it's also highly burdensome to the person and his or her family. So, recognizing that it impacts the entire unit, and by family, that is anyone who you identify as the person that would be your family. So that's not always blood relatives. Sometimes that's other forms of family that we identify with. So what exactly is a serious illness conversation? Because this is a fairly new term that's come about in the last 10 years. So if you're like me, I've been in healthcare for over 36 years, and this term was never used up until about 10 years ago when we started thinking about this idea of, paternalistic planning. Then we shifted it to patient-driven planning, and then we sort of moved it in the center to shared decision-making. And so this really tries to enforce this idea of shared decision-making. And so you're going to hear this type of conversation more and more as you move throughout your healthcare career. So it really is asking a patient about their understanding of their illness or their prognosis that can then help you with shared understanding of what that person knows and what you know. So that's sharing of understanding. It focuses on the patient's fears, their goals, their wishes, and limits of care. So really trying to understand, who is this person outside of the hospital or outside of the care facility that they're in? Who are they, and what's most important to them? We use a structured format that has patient tested language. So the format that we're going to be demonstrating today, and the guide that we are suggesting as a nice framework for these types of conversations, is already been tested. It's probably been published over, I would say there's probably over 500 publications on the serious illness conversation program and on the conversation guide, which are, the guide's part of the program. And you can Google search it and you'll get a whole bunch of information on it. It doesn't focus on treatment. So this is the key thing, is it's not about that care planning, that goals of care. It's not about, oh, I really am worried about my cancer. Well, let me tell you all the things that we have that we can do for your cancer. It's about, well, tell me more about what you're fearful of. What are you worried about? What are things that are really important for you that you feel you need to accomplish? So it's not going in that direction of, here, we've got treatment, which is often a direction we like to go in because we feel most comfortable with that, right? We feel comfortable with the medical, with the science of it. And so we're trying to sort of pull a little bit away from that and come in to the human aspect of the care that we provide. It should occur early in the course of a serious illness and life limiting. So we don't want to wait until the very end, because if we're waiting to the end, we're not giving that person the opportunity to do some of the things that are really important to them, to plan the way they want to plan. And so we can always revisit these conversations, but it's important to start them early. And they will look different as time goes on. The seriousness of the illness, the risk of death will look different. The timing in which somebody can prepare will look different. So we want to kind of pull it back as much as we can to early stages so that we're doing that appropriate planning. It provides a foundation for making decisions in the future. So if somebody said to me, I would never want to die in hospital. I feel like that would be the worst place to die. I'd rather die at home or hospice. We can then start thinking about that as time moves on, that, this person really doesn't want to be here. We should be thinking about transfer to a more comfortable environment if we know they're at the end stage of their life. So you can see how it can inform one conversation to the next. Or, I never want to go to ICU. I saw my dad die in ICU. I would never want that for myself. So now we're looking into further conversations about limits of care. And then it should be reviewed and revised over time, which I just said. It's valuable and therapeutic, even if we don't come up with a medical decision or recommendation for this person. Simply allowing space for open conversation and communication builds rapport quickly. And rapport is what we need to enhance trust, especially when we're making recommendations that are life and death. A person has to trust us in order to agree with that decision, right? If somebody's telling you something, if you're going to your mechanic and you don't trust them, and you heard they had a bad reputation, and right off the start they don't even ask you what's going on and what you're hearing in your car, and all of a sudden they're making all these recommendations, you kind of take a step back and go, wait a minute, do I really trust this person? Maybe I should be going somewhere else. And so by the approach to this conversation is to build that rapport, so that we build that trust, so that when we have to make those difficult recommendations, the trust has already been part of the foundation of that relationship. It's also a team approach. So a lot of people will say to me, but Sandy, I don't give prognosis. So right at the very beginning of the guide, it talks about sharing prognosis. And every one of us has some way in which, in our health profession, we give prognosis. So if I'm a therapist, I'm talking about functional prognosis. If I'm a nurse, I might be talking about uncertainty prognosis. If I'm a nurse practitioner or a physician, I might be talking about time-based prognosis. So there's all different ways of delivering prognosis. And sometimes it's the people that are at the bedside day in and day out that are seeing the decline in the person. They're hearing all the information coming in about what's going on, and they're able to approach that person and talk about their concerns about the decline of the patient. And, like social workers, all of our therapists, our nurses, our physicians, we all work together as a team to care for that person. And so these conversations are meant to be extrapolated to whatever profession that you're coming at the care in the care circle. So this is our usual conversation. And so in my practice in healthcare, I was a bioethicist for over a decade. And this is when conversations were occurring, when somebody was really short of time and their function was really low. And when somebody was obviously dying, Somebody said maybe we should talk to them about what they want and start setting limits of care. When really the conversations should start early, when the person's able to contribute, and also when the disease is early and we're not seeing that really late stage of the disease. So we want to move this conversation to usually when it happens to more in the front end. And again, you're seeing these gray spots where it's when the person's function is at its lowest, or when they have a really deep dip in their condition, and then we're addressing it, when we really should be doing it when the person's function is at its optimal and early on in the course of that illness. It's not focused on medical decisions. It's an opportunity. It's not an opportunity to discuss levels of intervention and code status. So I always say to people that it might come up, and that's totally fine, but don't go in with the agenda of, I need the code status, so I'm going to use this guide, because then you're using it wrong. You're using it to come up with an end result that you've already determined you want, versus allowing the person to talk and it coming up organically, or making suggestions that you revisit the code status based on what the person is telling you. But it can inform decision-making and care planning, and it is valuable even if the code status is known. So sometimes we know what the code status is, but there's so many other things that we need to be making. So again, DNR does not mean do not care, right? Our DNRC forms don't mean do not care. So there's lots of decisions that we still need to make. Transitioning to another facility, whether or not we do feeding for comfort versus feeding for maintaining somebody's nutrition, whether or not we're using blood pressure medication to keep the blood pressure up. So there's lots of decisions that need to be made, even if somebody has a no code status. So we need to keep that in mind too, which means that, still understanding the person's wishes are important right up until the end. And it can be a way, it can be used as a way to revisit values and goals and decision making. So here's like the systematic approach. So this is kind of like the high level. This is what it would look like to engage in a serious illness conversation. So first of all, we got to select the right patients, because we don't want to be having this patient on all patients, because we'd be overwhelmed with just talking to people all day long. So we want to make sure that, as a program, we identify these are the people we'd be most worried about, and this is the optimal time to have this discussion. We want to also prepare the patient. So if we're preparing them, say, for example, they have an endoscopy the following day, or a colonoscopy, we're telling them what's ahead, right? We're telling them what to expect. And so the same thing holds with this type of conversation intervention, that we're letting them know we want to have a conversation. It's really important that we understand who you are and what you value, because that's going to help us care for you properly. It's going to allow us to know you a little bit better. Here's some of the questions that we might be asking you when we have this meeting, and take them home, talk about them with your family, or when your family comes into the unit, or you're the substitute decision maker, maybe go home and talk to your family about some of these questions. And you're going to see what the questions are. So the patient comes prepared, and it's like any one of us who is put on the spot to answer a really important question. Sometimes we struggle with that, right? I don't know about you, but I usually walk away going, darn, I wish I would have said this, right? And so you want to give that person the opportunity to prepare. We also need to remind each other, this person, we don't really know what they want for themselves. We need some good planning. So there's also that reminding each other that this might be the inappropriate person. And then we're going to engage in that discussion with patient or the family member, the substitute decision maker. And I always say, if you have a capable patient, don't exclude the family, because sometimes the decisions that the patient is talking to you about are then going to be made by the family, and it's better for them to also hear it from the patient. If the patient is incapable, don't exclude them, because we still need to have their voice at the table. So we would always continue to be talking with them, even if they're not the ones that might ultimately be making decisions. So either way, we should have the patient and the family in the room, ideally, if we can. And then, of course, the most important thing, well, maybe not the most important thing, but a very key point, is that we need to document, right? So we need to make sure that these discussions are documented. Every organization, I find, has different ways to document. On the Epic board, there is notes that have serious illness, goals of care, and advanced care planning. You can actually label it that way. It also has smart text so that you can have the actual templates of each of those conversations, and you just need to fill them in. So that's always a good thing too. So that would be your documentation. It's also very important to make sure that if somebody, if the person is a readmission, or the person ends up in ICU or is transferred to another unit, these good conversations are understood by all. So this is the guide. This is what it looks like. And this was created from a gentleman named Atwell Gawande, who you may have read his book, Being Mortal. And Atwell went to a number of his palliative colleagues and said, listen, these conversations are hard. I'm seeing people come into my ICU and I'm thinking, why are we doing surgery on this person? Has anyone asked them what they want? And how do I go about asking them? So he asked a number of colleagues who he felt were really good at these discussions. And then he came up with a checklist, just like OR surgeons do, right? There's a checklist that they have. And before, anyone is operated on, they make sure everything, the T's are crossed, the I's are dotted. And so they basically came up with this program, and then they said, okay, we're going to test it on patients. They tested on thousands of patients. They revised it, revamped it, and then they published it. Actually, they didn't they did eventually publish. It's published a lot, but they began to test it in Ariadne Labs, which is an innovative testing site. If you haven't heard of Ariadne Labs, they do all kinds of different medical interventions that are very innovative. And so it really grew from Ariadne Labs. And Canada has now taken the program and has implemented across Canada. It's actually implemented in 52 countries across the world. And in Canada, it's in all provinces. And Pallium is one of our central educational hub sites that has this program embedded into their courses. And then there's a number of facilitators who can offer this as well. We've got a number of facilitators at HHS that don't necessarily do it through Pallium, but have their own slide decks that they can do it from and certify people. So there's lots of resources out there to help you if this is something you'd be interested in. So basically, the one side is really giving you sort of a guide to bring you from one section of your discussion into the next section. And then the opposite side on the right side is the patient tested language. So this is language that can be used with the patient. And you can see sharing prognosis, although it takes up a lot of white space, it's really not the big focus of the conversation. The focus really is on exploring key topics. And so you can also see the prognosis. There's one, for uncertainty, for time, and for function. Okay, so using that wish, worry, wonder is really helpful. And I went through that wish, worry, wonder last week, and this is where it's really pulled into the prognosis portion. So as we walk through the conversation, we set up the conversation so that it's set up for success, right? And part of that setup is preparing the patient, introducing, understanding how they like to receive information, asking permission. Is this a good day? Because something may have happened in the morning that they're like, I don't want to talk about this today. And then understanding illness. So what is your understanding of your illness? And then, can I share my understanding with you? And how much information from me would you want? The next is then sharing that prognosis, right? So really, again, keeping in mind that you are having this conversation with this person because you are worried they're going to die. And their prognosis is poor. You know that you need to prepare them. So it's not like you're having a conversation that's pulled out of the blue with somebody who, looks pretty good, probably has 5 more years to live, like their disease isn't that severe. This is somebody in front of you that you're going, yeah, I'm really worried that things are not going well for you. And you want to paint that picture of reality for them. And then exploring those key topics again, getting a real good understanding about what they want. And, for those of you that were with us last week, I shared the Healthcare Consent Act does talk about, the person's last expressed wish, while capable, that's applicable to the situation that should be used. And so understanding, what did that person tell you, when you're talking to the substitute decision maker, what's most important to them? What do they want for themselves? And then this idea of closing the conversation, so summarizing what you've heard, and then also making recommendations. I've highlighted this because this is really important to get to this point where you can actually make some recommendations. And I'm going to demonstrate, how we would go about doing that. But those recommendations might be, I think we really need to have a discussion with the physician about limits of care, because you've told me some things that I'm worried that, when things start to fail for you, we may not have the right plan in place if, given everything you've told me, or, it really sounds like you want to get home. And I think maybe we should consult with our social worker to talk about further discharge planning. So there's things that you can pull into making the recommendations. The recommendation is, and I'm going to recommend that we, increase your blood pressure medication and give you a blood transfusion, right? That's a medicalization of the illness, right? So we're trying to not pull that in, although it might be something that we use in future, right? So just trying to make those recommendations that are based on what you're hearing the patient say. And then, the documentation, which I talked about, potential next steps, we've talked that it can lead to code status. It can lead to, even the DNRC form, right? Patient is going home, doesn't want to, be resuscitated. We need to make sure we have that do not resuscitate confirmation form that's being sent home with them and then documented in the record. So what are the benefits? So, sounds great, right? But is this really going to work, and is it helpful? So this has been published. There's hundreds of publications about the benefits to the clinician and to the patients. So for the clinician, training for these very emotional encounters helps reduce burnout among clinicians. So it reduces our stress, it reduces our anxiety. We feel more comfortable. We feel like we're able to fulfill our jobs to the completeness that is expected of us. So it does reduce that anxiety and burnout amongst clinicians. It reduces, I said anxiety, also satisfaction with your role, right? Knowing that you've made a difference, knowing that, you went through this hard conversation, but at the end, you're feeling like that person has more of an opportunity to prepare. So, that helping that professional role that you have improves job satisfaction and fulfillment, and information is easier to retrieve by other clinicians. When we actually go through this program, we document these really important conversations, so the person's, one, not having to repeat themselves, but also we get a good understanding of what the family knows, what the person wants for themselves, what their fears are, what they're hoping to achieve from, coming back to the hospital or during their stay in hospital. Benefits to the patient, we do see fewer hospitalizations and earlier integration of palliative care. So when we understand that a person, they understand they're dying, they don't want to come back to hospital, it's the last place they want to be, or they don't want to medicalize their death, or they'd rather die at home, or they don't want to be in the ICU, we can then put in place in the community things that will help keep them in their home, such things as their palliative care. Some of our communities have the paramedic palliative care services. Sometimes people just call because they're worried that their loved one is deteriorating, and they don't necessarily need admission to hospital, but they need somebody to come out and help them, or have a brief stay in ER to help manage those symptoms so they can go back home. It does enhance goal concordant care and improves quality of life. So we know that there was a study actually published that was done at HHS that showed that when we don't have these discussions, we often will document things that patients don't want versus aligning with their wishes. It reduces anxiety and depression amongst patients. So that certainly is something that has been studied, particularly in the cancer population. People think, oh, I'm going to cause them to be more anxious. They're going to be more fearful. I'm going to take away hope. And so none of these things have been proven. It may not reduce anxiety and depression in all patients, but for more than not, it does. And so, we can't be fearful that, we're going to cause harm to the person. We actually cause more harm when we don't engage in this honest discussion. Better patient and family coping, and improved bereavement outcomes. So I'm just going to ask, when do you think a serious illness conversation should occur? So I'll give you a minute to answer that poll. And Tina, you're on mute, so.
Yes, I'll just wait for a few more
Yep.
responses.
Yeah, and I think you can choose all that apply here.
Okay.
So what
We'll
if
just
people
give a
think?
little bit longer because I know
Yeah.
there's a little bit more to read for this question.
Yeah.
Okay. I still see responses coming in.
Okay. Yeah, actually, I just opened the chat and I think I can see them.
Okay,
Yeah.
in the
So
chat. Yeah.
yeah, so it looks like it seems again across the board, which maybe you're selecting a number of them, but um, yeah, so I'm going to just show you this next slide because this is going to help speak to this. So these are just examples of triggers that can start the conversation. So if we have somebody who has a decline in functional status, so you may be using the frailty scale, you might be using the palliative performance scale. So you can use different scales that are going to tell you this person is heading towards end of life. We also, have diagnosis or prognosis that has a high risk of death within the next year. So in your specialty, you may determine that this person's risk is high, and that might be due to some of the prognostic tools that you're using to determine that. Comorbidities with client declining conditions, we see this a lot with our senior population and frailty. Multiple hospitalizations that are becoming more and more frequent. So we're seeing this person admitted, 3, 4, 5, 6 times a year. A request for patient family to discuss end of life care planning. And I've talked about the prognostic tools. And then we always say in your own program, in your own specialty, it would be helpful for people to come together to say, like, who would we want to have this type of discussion with? So I'll just give you an example of the Cancer Center. So they decided on a number of different things. So they've sort of put it together as time-based. So would you be surprised if the person died in the next 12 months? Specific diagnoses like glioblastoma, advanced pancreatic, advanced non-small cell, cancer-related complications, so solid tumor or brain metastases, treatment related, so if somebody's moving to third line palliative, and then clinical status using the ECOG or the palliative performance scale. And so you can see they've done a very thorough job in saying, okay, which one of our patients, if they've met some of these triggers, are going to tell us we need to have this discussion. We're going to go back to Marita's story. So for those of you who know, Marita had a stroke. She had some issues with swallowing. Son was very hesitant to agree to a feeding tube. He didn't really understand the difference between temporary and permanent. And so the team ended up having to, really coax him into coming to have a conversation. And once he had a better understanding of that it was a temporary tube to help Marita recover and regain her strength and avoid any microaspirations that she was having, the outcome looked really good. And the team was really hopeful that she'd have a fairly decent recovery with continued good quality of life. And so Son agreed to the feeding tube, a temporary G tube was put in, and all went well up until 2 weeks later. So consent was signed for that, no problem. That was the goals of care conversation. And then 2 weeks later, unfortunately, Marita had a subsequent hemorrhagic stroke. It was much more severe than the first one. Her brainstem had been affected and her prognosis was extremely poor. She required supplemental oxygen to keep her oxygen levels up and a BiPAP to assist with breathing. She has minimal reflexes and is not able to swallow or protect her airway. So she's gone NPO, so she's not being fed anything, and she's non-responsive, and she has displayed signs consistent of seizure activity. The tests are pending, but given the MRI and the diagnostic imaging, the team is not hopeful that she will have any significant recovery from this, and that her condition is likely to just deteriorate. So the trigger for the conversation for Marita, she has a poor prognosis associated with the location and severity of her stroke. There is a high probability that Marita will not have the ability to sustain life without plus support. So, really, she's on a downhill slant, and she would need a lot of medicalization and intervention when she does start to deteriorate. And the son is asking when Marita will be transferred to the rehab floor, which was the original plan during the first stroke. So there is concern that we need to revisit the prognosis now. This is just, again, the impacts. I'm just going to skip through that. So I'm going to stop sharing here. And I'm going to introduce you to Santo. Okay, so this is stop sharing, right? Yeah. Okay. So I'm just going to introduce you to Santo. So Santo is Marita's son. He is the substitute decision maker by appointment. So he was appointed as power of attorney for personal care by Marita. And he does have siblings, but it's just Santo here with me today. And so I've been the nurse practitioner that's been helping look after Marita. And I've asked Santo if he can come in and have a conversation with me. I did share with him the information that I'd be asking, and he was a bit surprised because he, usually we talk about the medical stuff, but today I told him that look like a little bit of a different conversation, that I would give him lots of opportunity to tell me more about his mom, and what things that he felt she would want for herself. And so he's willingly come in to chat with me. And so I'm going to have this discussion with him. If you, during the discussion, you would like to ask Santo anything after the discussion, as a patient family advisor that he is, and also a simulated patient, please feel free to put it in the chat, and we'll make sure that those questions get asked as well. Okay. So we're just going to start the conversation. So hi, Santo. Thanks so much for coming in today. It was really nice to see you.
Thanks for calling me and letting me come in today.
Yeah, no problem. So Santo, today I know I had talked to you about this being a little bit of a different conversation. I do have a guide, and the guide for me helps me to remember the important questions I want to ask you. So if I look down at my guide, it's not because I'm not paying attention to you. It's just because I want to make sure I capture everything I wanted to ask you today, so I get to know your mom a little bit more than I already do. So today, I'd really like to talk to you about what matters most to your mom and what matters most to your family. So are you okay to have that conversation today?
Yes, yeah.
Okay. So in order for me to make sure I share information that would be helpful, it'd really be helpful for me to have an understanding of, what your understanding is of your mom's health at this point.
At this point, I understand that she's taken a turn for the worst, and that things don't look too positive.
Yeah, yeah. So yeah, I'd like to share with you what I understand, but before I do, I just want to get an understanding of how much information do you want from me today about her, situation?
Well, I'd like to know what medically is going on with her, and how or if her condition is affecting her in any way, and if you can provide some kind of timeline as to when things may happen or not happen.
Yeah, for sure I can. I can. I really wish that we were having this conversation under better circumstances. And I wish that, everything that's happening to your mom was not not happening. Obviously, I know that things were really going well, and then she's taken a turn for the worst. And I do have to say, I am worried that that time might be running short for your mom. And by that, I mean, we're looking at potentially days to a few weeks.
Wow.
Yeah, and I really do hope that that maybe we get a bit more time with her, but I am worried that time is running short for your mom.
And what spurred was there any reason that the second incident occurred? How did that happen when we thought originally we would be in a different position?
Yeah, yeah. So unfortunately, it's not uncommon for somebody to have a secondary stroke, subsequent stroke after one has already occurred. And sometimes it's just nature that takes over from what we can do as health professionals. So I am wondering, at this point, what do you think your mom's most important goals would be?
Well, she did talk to us, especially after my dad passed away,
Mhm.
and she saw my dad suffer uh, through what he was going through, and she always, she doesn't want to go through the same suffering, and she also doesn't want anybody else, especially her grandkids, to see her not capable of, being able to play with them or looking
Yeah.
very sick. So her goals are basically those two, really, is nobody else to suffer and for her not to suffer.
Yeah. Okay. That sounds really reasonable. And I think it does sound like she's has had that experience with her husband, and that was maybe, something that was helped her
Uh,
inform her future decisions.
yeah,
Mhm.
definitely.
Yeah. So what do you think her biggest worry would be?
Um, I think her biggest worry is, being hooked up to many machines or and suffering while she's being hooked up.
Mhm.
Um, she had to go through that with my dad, and it was a very difficult decision for her to start unplugging everything
Yeah.
because they had not had the conversation. So she herself doesn't want the family to go through that as well.
Yeah.
So she basically, again, it comes back to uh, us watching her suffer.
Yeah.
She doesn't really want. That's probably her biggest worry. And as well, if she's hooked up, she's not suffering.
Yeah. So it does kind of bring me to one of the questions that I had. And, that question is, what would your mom be willing to go through for more time? Or, sometimes we talk about the idea of, what would be her trade-offs? What would she be willing to trade off for more time?
Uh, That's a difficult question because of the situation we're in. Number one, I
Yeah.
think um, uh, I don't think if she can't function and she can't enjoy her grandchildren, um, and as she did, I don't think there's uh, um, any lack of better words, wiggle room that
Yeah.
you can introduce something to keep her going. I think
Yeah.
that she would, I think her intention would that she would want to die peacefully and be with her husband, my
Yeah.
dad.
Yeah. So sometimes how we phrase that is that a person really wants to focus on having a good quality of life for as long as they have left, and versus,
Uh,
trying to buy more time with different things that we might be
so
able to do.
yeah, I think from what she has talked to us about that she's comfortable during
Yeah.
that
Yeah.
that part of her life.
Yeah.
Yeah.
Okay. So how much does your family know about your mom's wishes? Because I know that you have two siblings, and so I'm just curious, how much they have, like how much of an understanding do they have of what your mom would want for herself?
Well, that part is pretty good. We're all on the same page there
Hmm.
as far as what my mother wants. My mom always told the three of us that if she's plugged in, to unplug her because the only one suffering is us and not her. So we're all on the same page there. But I don't think I can explain what's happening to her as well as you can.
Hmm.
So, if anything, I would love if they could come in and you can explain it to all of us at the same time.
Hmm. Yeah.
Because I think if I had to go back to them and try to explain it to them, I don't think I'd do a good job. Plus, I couldn't answer any of their questions if they had any. So,
Yeah.
um, yeah, so I think if that part, the medical part, I would definitely need help with.
Yeah.
Yeah.
Okay. Okay. So it sounds like your siblings have a good understanding of what your mom would have wanted for herself, but this current state, it would be helpful for us to support you in having that discussion, or having your siblings involved so that they have a good understanding as well.
Yes, yeah,
Yeah,
totally, totally.
that's fair. So, Santo, what I'm hearing you say is that your mom, what really brings her joy is her grandchildren, and that
Yes.
their grandchildren were a big part of her life, and that she, has this care for you and your siblings of not wanting you to suffer if she's suffering.
Yes.
I'm also hearing you say that your mom had that experience with her spouse, your dad, and that wouldn't want to experience the things that he had to go through, but also the challenge that you had with making some really difficult decisions. And so kind of expressed already to you some of the things that would be important to her when it comes to limits of care. Does that
Yes.
sound like I have that correct?
Yes, and that goes along with what you have told me about her prognosis.
Yeah.
Yeah.
Yeah. So, keeping all of that in mind, what I'd like to recommend, a couple things I think we need to do moving forward. I think first we need to set up a meeting with Dr. Yusuf to talk about more about the medical aspects of what's going on with your mom so that there's a better understanding and have your siblings as part of that conversation.
That would
I
be
think it's,
great.
yeah, I think it's also important uh, that we also talk a little bit more about what we can continue to do for your mom. So, what are the things that we can do to keep her comfortable? Because I've heard you say a couple times about suffering. So, I want to talk to you about those things. And then also the things that would be really inappropriate to do for your mom, because as time goes on, your mom's body will become weaker and weaker. And we need to be able to support that natural process of dying versus coming up with ways to intervene with that. And so I'd like to make it, pretty clear that we want to allow her to die naturally and not intervene with that.
Yes, and her wishes, even if some of her, you know, sisters or that don't agree with it, is
Yeah.
that definitely if she is on that path, that it's comfortable for her, and me and my brothers and sisters would also want that for her, that
Yeah.
it's as comfortable as it can be during
Yeah.
that time. Yeah.
Yeah. Yeah. And we do have a palliative care consultation team that we can consult to see if there's any other things that we could be doing to support your mom, while she's here with us and maybe potentially for any future
Yeah.
location that she might be. Yeah.
And and could you recommend too if some of us need some help as well?
Absolutely.
Absolutely.
Yeah. I know that you're connected with our social worker, so I'm going to document all of this if that's okay. And
That's
maybe
awesome.
I'll touch base with him before I go home just to let him know that, we had a bit of a hard conversation today and that, support would
Yeah.
be helpful.
Thank you.
Okay. Okay. So I just want to remind you that, we're in this together and we're going to try and do everything we can to support and honor your mom's wishes and the things that are important to her, and really do all we can to alleviate any suffering that she might be experiencing.
Yeah, we would be very thankful if you could do that for my mom. Yeah.
Yeah. Okay. Thanks, Santo, and we'll be in touch.
Thanks, Sandra.
Okay. Okay, so timeout. So that, folks, would be how we would go through a serious illness conversation using the guide. So all of the questions that are on the guide, I was able to ask Santo, which, is often people become a little bit overwhelmed, feeling like, how am I ever going to get through the entire guide? But it actually streamlines the conversation so that you're really zoning in on the things that will help you develop those recommendations and plans. So I'm just wondering if there is any questions that anyone has.
If anyone would like to raise their hand, we can certainly allow them to unmute and ask it, or you can put it in the chat or in the Q&A as well. One of the things I was thinking, Sandra, is this is a great introduction. And do you have some suggestions for where we could go for more, to learn a little bit more about the goals
Yeah.
of care and the serious illness conversations?
Yeah, for sure. So Pallium, which is pallium.ca, they offer courses, but oftentimes you have to have a facilitator that's in your organization to create a course and then offer that course. They're not just kind of hosting open sessions. At Hamilton Health Sciences, we are offering them the last Wednesday of every month. And so you could simply email sic@hhsc.ca, and I can put that in the chat here. So we are offering those courses. They're open to 12 people, and 12 people a session, because when you break out into the breakout rooms, you get to actually practice trying the conversation, and with a facilitator that can give you tips and tricks on how to have the discussion and answer any questions that you might have about end of life conversations. And then also, we had also talked about potentially offering a course for the Ontario Stroke Network. So if people were interested, we can create a course on the Pallium site so that they can log on, and it would be specifically for members of the Stroke Network. So that's another opportunity as well.
Okay, thank you. Before we go to the raised hand, there is a question in the chat. Just noticing that, Santo was pretty calm having this conversation. And do you find that
And
that is the norm, or that families are often quite emotional having the conversation?
Yeah, so families are, yeah, there is emotion definitely that's attached to these conversations. And actually in the program, we talk about the acronym NURSE, which is to how you would address emotion, right? Because we have to, first notice it. We have to, address it and have understanding of what's going on, and be empathetic. And, I have a colleague of mine who teaches the SICK program. He's an oncologist here in Hamilton. And when he teaches, he tells people, I don't say a word after I give prognosis until that person speaks first, because they're digesting, it's emotional. We know that these conversations are hard. And so we have to allow for those emotions to come up. We also, the idea of anger, right? Like, people often think they're going to be angry. And, to address that, simply by saying, you seem really angry right now, and I can understand why that would be. Or you see somebody crying, tell me a little bit more about your tears, tell me where they're coming from. um, you know those sorts of things are ways in which we can address the anxiety or the frustration that somebody has. I think that what tempers people's emotion is when they feel like you're listening, when they feel that you genuinely care. And when you say that wish, worry, wonder, I wish, you're hoping, you're hopeful. You understand that person's hope. You worry, that's compassion for the person. And you wonder, that's curiosity. Tell me more about what you want. So that wish, worry, wonder also helps to build that rapport and address those emotions that people have. Yeah.
yeah,
And
I just,
definitely, yeah. Go ahead,
yeah,
Santo.
yeah, I just want to add one thing, just so everyone knows I have been through this a couple times. And one of the things that you're right, emotions are there. Yeah, but Sandra's right. The communication and the listening, and then um, showing that the understanding, where 2 or 3 meetings later, they remember what you said, this little thing that you said. So suddenly you're comfortable in the room with them, and the discussion goes a lot better.
Yeah.
If you're going in every meeting, and you're regurgitating everything you'd already talked about, then it won't go well. Like, it just won't. You'll get angry. Then the focus shifts from the patient to you, and why isn't nobody listening to me,
Yeah.
kind of stuff. So
Yeah.
just to reinforce what you said, Sandra.
Yeah. Thanks, Santo. And when Santo says he's been through this a couple times, he's a patient family advisor because he has been through this with family members. Yeah. I see that our SLP room has their hand up. I wonder if you want to unmute yourself and, yeah. Hi.
Everyone, I'm Nadine. I'm a stroke SLP. Just want to say thank you so much, Santo. It's always helpful to hear from families. If you think back to when you were really having that conversation, do you have any feedback for the team that you felt went well or could have been different that we today can learn from?
Um, I it it For all intents and purposes, it went well. As looking back at it now, when I was going through it, I would say that coming home, it never went well because the prognosis was never good. So you have to keep that in mind when the patient's coming back. But if anything, it wasn't the nurses or the admin. The doctors were, I found, and I guess that's just their job, very blunt in how they were reporting the facts. And it was the nurses and the admin that provided all the comfort and care afterwards. And that's probably the only criticism. I was at Joe Brandt and at Juravinski and at the General for my mom, and all three times I can't say enough about the staff, you know, and how comforting they were during what we were going through. But the only criticism I have, yeah, is that when the doctor dropped the bomb, he really dropped the bomb. And I mean, thank God Maria came in after her and kind of calmed us down and you know, and steered us in the right direction. Yeah.
And I think, Santo, it speaks to the idea of sharing prognosis, right? And how do we go about sharing prognosis?
Yeah.
So, you know, we bring that wish, worry, wonder, right? Like, I really wish I didn't have to give you this information,
Oh.
but I am worried that time is running short, and I'm wondering, you know, I want to hear from you what's most important. You know, that using that language to share that prognosis is
Yeah.
critical, right?
And I understand now. I mean, it was difficult when the prognosis keeps changing, and you have to deal with a different situation after every visit, and you know, and you're just you don't want to think of what's going to happen in the end, but at some point you have to you know, seriously think, because you're the person that has to deal with the doctors, nurses, and the decision making. And I wouldn't wish it on anyone. It was a very difficult time. Not so much for my mom, because she educated me and my sisters before anything happened for many, many years. And that quote of unplug me, that was my mom. So we were very fortunate that we were able to make the decision when nothing else could be done. But with my wife, it was very difficult. The prognosis kept changing, more tests, different therapies, different chemo. You know, so it was very hard to keep up with what was going on. But you know, at the end of the day, I think what helped me through it was as the mother in Sandra's little thing, I wanted my wife to be my thought process was, I want my wife to be as comfortable as she can be through this whole thing, and that kind of kept me going.
Yeah. Thanks, Santo.
So we are just after 3 o'clock, but if you're able to stay another couple of minutes, we do have one more person, Natalie, with her hand up. So Natalie, I've made it, allowed you to unmute and use your camera if you would like.
Okay. Can you hear me okay?
Yes.
Yeah.
Okay. My first question, I'm assuming like a goals of care discussion would have already happened, so the family would be aware of the prognosis, right? I'm a social worker, and I worry, like the doctors don't always have time to have these detailed conversations, but I feel like I could take the time to really explore the serious illness framework. But I just wanted to make sure, I just wouldn't be uncomfortable being the one to share the prognosis with the family.
Yeah, for sure. And there's actually a guide for social workers for the SICK program, because a lot of times social workers are the ones that are coming in after. And that idea of uncertainty is a really good way to share the concern about what's going to happen in the future, right? And that's, you know, prognosis isn't just about here's your disease and here's, you know, how it's going to progress from a biophysical nature, but, you know, how are things going to unfold for you and your family, given the bad news that you've just recently been given, and can we talk a little bit more about what's most important for you? And you can see, you know, in this situation where, you know, a lot of information that the son was sharing was, we were able to start thinking about, you know, limits of care, what happens when you go home, what, you know, what supports would be helpful for you, how can we communicate with your family. So those things can all then be, you know, relayed to the other team members. And that's why I say this is a team sport, right? It's not just about, you know, a physician giving a prognosis of a disease. This is, you know, almost like a life prognosis. We have to think about it as, right? We're dealing with people that are going to die, and how do we support them as best we can to, you know, ensure we do the right thing for their loved ones. So great question. Yeah.
How do I
Yeah,
find that specific guide you were talking about?
Pardon?
For social work, you said there's a specific guide?
Yeah, so the SIC has developed a supplemental workbook. It's just a 3-page, and it gives social workers also sort of language as well that follows the guide. It just shifts the language slightly, and then just shares ways that they can make recommendations as well.
Awesome, thank
Yeah.
you.
So I'd be happy for people to, if the Stroke Network, Central South Regional Stroke Network wants to set up a SIC program, like we can certainly offer, you know, a course to your group, and maybe that's how you kind of you end your 4 weeks of different education, is we can plan a date that you know, it's about a 3-hour commitment to go through the whole